This slide is just an overview to start us off with a reminder about our therapies. So naturopathic immunotherapy is about treating the whole person. And while yes, we have this goal of lowering CRP and inflammation, the way we go about that goal isn't just about giving natural agents like the previous slide. It's about helping to manage sleep because that keeps inflammation down and immune system up. Manage stress because that keeps inflammation down and immune system up. Social connection really impacts immunity. The human microbiome, proper nutrition. So I have to remind us all that the foundations of our medicine, the foundations of health, sleep, exercise, healthy relationships, stress management, good food, good nutrition, avoidance of toxins, that is the same whether we're dealing with general health concerns, COVID-19, or cancer care. Some of our first line physical barriers that we think about are worth mentioning because pathogens do need to get past our stomach acid, the pH in our stomach acid, and antimicrobial enzymes in our mucus in order to infect us. So snot is our friend. We can encourage healthy mucous membranes with adequate hydration, especially with teas. And mucilaginous herbs come to mind like marshmallow, slippery elm, licorice root, which we're going to talk about in more detail afterwards. Cinnamon is also mucilaginous. Lactoferrin, which is a supplement, is also naturally occurring in our tears, our saliva, and our nasal secretions, and that inhibits SARS-CoV cell entry in petri dishes. So thank you to our mucous membranes, and let's keep them moist. Dry tissues can be addressed with humidifiers in the bedroom and with aromatic steams. It's especially been hard to get supplements and nutrients in a timely fashion. And one of the things that most people have already in their kitchen is things like thyme and oregano and sage, and they make wonderful kitchen steams to hydrate and also the aromatic properties of those essential oils and those kitchen herbs help to open up and have an antimicrobial effect on the surface as well. So that's simple first line approaches. Also, our first line is our gut-associated lymph tissue, which is the largest organ in our largest part of our immune system. And that has both a local and a systemic effect. So the GALT signals from our gut to the rest of our immune system. And the GALT system is very modifiable with diet. So I recommend a Mediterranean diet rich in fruits and vegetables and legumes that will induce a diverse flora. We can especially focus on microbial diversity with things like fish and fish oil, fruits and vegetables. Exercise will have an impact positively on our microbiome. Nuts, soy, high fiber diet, and fish oil itself. When it comes to probiotics, an interesting side point is that patients with COVID-19 who were inpatient in China, many of them had intestinal dysbiosis with decreased lactobacillus and bifidobacteria, so that's not a huge surprise. If people don't have a healthy microbiome at onset, I think it is reasonable to supplement with probiotics. We do have a trial in the elderly and in the young that probiotics will prevent upper respiratory tract infections in the winter months. We also have an in vitro study that particular strains will inhibit coronavirus TGEV, that's the enterovirus part that you often see in livestock. In mice, we see some effectiveness against influenza and stimulating interferon type 1 responses. And then we have a human study that probiotic strain can improve sleep quality by reducing stress. So I think I put these in here just to illustrate how much our gut feeds back into our systemic immunity and how it really is a first line of defense that we shouldn't forget about in our assessments for immune function in our patients. Some thoughts about physical medicine for COVID-19, aside from sleep and stress management, are the possible role of fever and hyperthermia. Hyperthermia is available sometimes through hyperthermia machines in integrative oncology, but also things like warm baths or bundling up during a fever and letting a fever run is an approach. There's a great study I left There's an open text study listed right here in the slides that has a wonderful overview of how fever stimulates both the innate and the adaptive immune system. So as long as a patient is comfortable and staying hydrated, I'm really happy to let a fever run personally. And patients will often say, what degree fever do I need to worry at? For me, a fever is not about what the thermometer says. It's how sick the person is. So you can have a kid who's running around with 101 fever and jumping around with energy and clearly does not need any support, whereas someone else can have a lower fever and feel awful and be glassy-eyed and out of it. And so you might consider interfering a little bit more with supportive care. So it's not about what the fever says, but I do, in reading and learning more and more about how fever impacts our immune system, think it's a good idea to allow a fever to run, because it does have this initial upregulation of innate immunity, and then it helps to trigger resolution of that immune system, which is exactly where things kind of get dysregulated with a cytokine storm. In looking at a 2019 review article, I think it was from BMJ, on antipyretics, or medications that reduce fever, 2 studies demonstrated improvement in patient outcomes, but several studies demonstrated increased mortality risk associated with inpatient use of antipyretics. So fever might actually be an advantage for our critical patients. We just don't know. So I think that the whole ibuprofen Tylenol thing is controversial for good reason, and I would rather leave it out if someone can let a fever run comfortably and sleep. I mean, I would interfere if sleep was really an issue, because sleep is sacred. But and just a slight awareness about alternating hot and cold therapy, which is sometimes used in hydrotherapy for infection or for upregulating the immune system. Like exercise, that seems to increase interleukin-6 a little bit, which may not be such a good idea, depending on the timing of that, when it comes to more severe infections. So caution in that area. Some botanical considerations for COVID-19, or herbs. Astragalus is the first and I would say most important herb that comes to mind when thinking about what we can do for COVID-19, especially for those mild to moderate infections that we're seeing out there in the general community. These are not patients who are in respiratory distress. They have a cough, they have a fever, they feel flu-y, they're going to get over it. We want to give them a little support. In 2 different avian studies, astragalus inhibits coronavirus. From a traditional Chinese medicine perspective, astragalus has been used for thousands of years. It's considered an herb that is safe for young people and old people. It supports our protective qi, or our surface immunity. It's a lung tonic. It's a moistening adaptogen, and COVID-19 tends to be dry, so I think it's well suited. We'll see in a couple of slides how commonly astragalus is used in China, in all the different provinces, for COVID-19 specifically. Licorice root is also one of the top 10 most commonly used empirically for COVID-19 patients. Licorice root inhibits the SARS coronavirus in vitro. As early as 2009, licorice root was proposed as a basis for an antiviral drug for corona, so following the first SARS outbreak. From a traditional Chinese perspective, it clears phlegm, controls cough, slows down acute reactions, stops pain and muscle spasms, and it modulates the harsher properties of other herbs. So it's used in conjunction with a great many formulas because it's a harmonizer between the different herbs. We do need to be cautious about higher dose licorice and hypertension, because in people with hypertension, a high dose of licorice can aggravate that, and hypertension, as I'm sure you're well aware, is a risk factor for more severe COVID-19. So know your patient base, know who you're dealing with, know what their blood pressure is like before using high doses of that. The other herb that's gotten a lot of play is elderberry, because it's been researched so much for influenza virus. We do have an in vitro study that it inhibits the viral replication of coronavirus. And in chickens, it reduces the viral load, the titers rather, of coronavirus. So some good preclinical research. There is mixed research on whether elderberry raises or reduces inflammatory cytokines. Historically, it has always been used as an anti-inflammatory herb. Most of the historical books will in fact call it an anti-inflammatory herb, and that's how I learned it, and that's how I've been using it for 20 years now. So I feel very comfortable with elderberry, especially in children who it's typically used in because it tastes good. And I do think it's a reasonable flu treatment. So I don't worry about the use particularly of elderberry during an active COVID infection. It's not it's not the top of my list, but I'm not overly worried about that. I do think it's useful for prevention, especially for people or kids who might not have a lot of colorful fruits and vegetables in their diet, because it has lots of anthocyanidins in there, lots of colorful pigment in there. The other herbs that I think about in a gentler way are garlic, because it's in people's kitchen cabinet easily. The research is a little weaker for that. In vitro, it inhibits coronavirus. Aged garlic does reduce the severity of colds and flus over the winter season when taken long term, like 3 months. Garlic definitely concentrates well in the lungs, which is why it gives you garlic breath. And again, it's an easy herb to find. It does have some drug interactions. It can be a blood thinner, so keep that in mind about garlic too. But the other thought is to consider green tea. So in a nice randomized controlled trial, healthcare workers who took green tea regularly had lower rates of influenza. So that's exciting. But green tea is a very drying tea for anyone who's taken it for a period of time. So think about combining it with a moistening tea these days. And then turmeric in vivo and in vitro has antiviral activity against a whole host of viruses. It's never been tested against COVID, but many of our patients are on turmeric in the cancer context. So rest assured that it does have, at least a baby amount of research on it as an antiviral. When we look to traditional Western herbalism for our therapies that might be available to support COVID-19 patients, again, with mild to moderate respiratory symptoms, we would think about antispasmodic herbs with caution and attention to dosing. Things like lobelia, which is a good rescue herb in drop dosing for lung spasm and wheezing and shortness of breath. Too much lobelia makes you nauseous and can actually make you throw up. So, know your herbs. Elecampane, which is gentler, but is a good antispasmodic. And then ephedra is not really available here and has a lot of safety cautions, but I thought I would mention it because it is still used in China, and it is being used for COVID-19 in China. In terms of moistening respiratory herbs for coughs, we have so many lovely herbs that grow right here in North America. Things like mullein, wild cherry bark, plantain, and violet leaf. So these are all moistening herbs that make wonderful teas aimed at the lungs. And typically they would also be combined with an antimicrobial herb. And again, lots of options there. Things like raw onion, bee balm, grindelia, andrographis, Osha, yerba mansa, lomatium. More for wet coughs, we'd have things like horehound and usnea, so they may or may not come up because COVID-19 seems to be more of a dry cough. But lots of options in which you can individualize a formula for herbs. And that's really how traditional Western medicine has always worked, is treating the patient, not just, a protocol or a certain cough combo, but individualizing the herbs for the unique patient that is experiencing the infection. And again, most Western herbalists are also using aromatic steams with oregano and thyme and hyssop and things like that. If people are the wild crafting type, then Douglas fir and white pine tea make a vitamin C rich tea. I actually just made a white pine tea the other day. Delicious. And very shortly, I'm looking out at my lawn, very shortly we'll be able to harvest plantain violet leaf for those dry coughs, and mullein will come up a little later in the season. So moving over to traditional Chinese herbs, in a Cochrane systematic review on TCM herbs for SARS, they concluded that the herbs were not able to decrease mortality rates, but we do have some decent evidence, not high quality randomized control trial evidence, but some decent evidence that 2 herbs may improve symptoms of COVID, or SARS rather. 5 herbs improved lung infiltrate absorption. 4 herbs decreased the dosage of corticosteroids needed for inpatients. 3 herbs improved quality of life of SARS patient, and 1 herb shortened the length of hospital stay. So again, I think since once someone's in the hospital, we're not giving them Chinese herbs anyways because they're isolated in the hospital. These herbs, their strength is in the treatment of these mild to moderate cases, and these Chinese herbs do have a role to play. One of the most common formulas used for SARS prevention in China is jade windscreen, which is a traditional formula, and that is composed of 3 herbs. Astragalus, Atractyloides, and Sapochnikovia. And those 3 herbs, interestingly enough, when we look at the most frequently used TCM herbs being used right now for COVID-19 in China, are those 3. Those 3 come up as a theme. And I don't have a personal relationship with Sapochnikovia, but I can definitely speak to many years of working with astragalus and licorice root, especially in tea and powdered forms. So it's nice to learn about what's happening in China. The Chinese government has, in fact, even done now its 6th edition of guidelines for the treatment of COVID-19 with traditional Chinese herbs. And they are recommending different formulas on this document for different phases of the disease. And I just thought it was noteworthy for those of us who work in cancer that 2 of the injectables that are being used in critical care cases in China are also injectables that we know from research in integrative oncology. And special thanks to Dr. Winston Cardwell for sharing his document here, where he's divided up common formulas that you can find here in the North American market for different types of illnesses as they manifest, early onset versus later on with a dry cough versus the gastrointestinal manifestations. So we can think about herbs that are created here by Western companies but are traditional Chinese in origin and have the quality control checks that we would hope that a company would go through here. So that's reassuring and also more accessible here. Moving on to nutritional supplement considerations for COVID-19, I want to preface this by saying it's very clear that deficiencies in zinc, vitamin C, or vitamin D all impair innate immunity and increase inflammation. So we want to definitely attend to any deficiencies that are there. We want to optimize our immune function by including these nutrients, but we also don't want to overdo it. And in people's fear and trauma, I think they are often overzealous, and I've certainly already seen that in patients where they think more is better. And with nutrients and with herbs, as with drugs, more isn't always better. More can become toxic. So we want to use common sense when thinking about these nutrients and not let fear push us to use too much of them, because you can have too much of a good thing. Right here, there's a wonderful open text article with great charts of the different nutrients and how they've been researched for the common cold. So that's a good kind of framework, even though this isn't a common cold, but it gives you an understanding of the role of these basic nutrients in management of infection. And starting with vitamin C, just a reminder that low vitamin C really can happen with low appetite, with malnutrition, with high inflammation, post-surgically, with radiation, in smokers, and late stages diseases. In advanced cancer patients, up to 40% of patients actually have a vitamin C deficiency. And in children, that number is 86%. So it's a plot flaw for us humans that we cannot make vitamin C. We have to consume it. It's a bummer. Other mammals can make it. We cannot manufacture it. We have to actually eat it. So we're susceptible to depletion of vitamin C very easily. Supplementation of vitamin C statistically reduces the incidence of pneumonia and common cold. And there's a linear dose response in length of hospital stay for pneumonia in patients who are taking vitamin C. So it looks like a little bit more is a little bit better, certainly with vitamin C. You will hit bowel tolerance if you take, which is a nice way of saying you'll get diarrhea if you take too much vitamin C at once. So I do think vitamin C is a safe enough nutrient and one that we're all comfortable enough that it is reasonable if someone has an active COVID infection to use 1,000 milligrams every 1 to 2 hours for 6 to 8 doses if needed, but just to really avoid bowel tolerance or warn patients about potential diarrhea. Zinc certainly has a role to play in prevention of COVID-19 and arguably treatment as well, but we again have to be careful about too much of a good thing. Zinc deficiency is very common in the elderly, and if undiagnosed, causes T cell malfunction and increased respiratory tract infections and poor responses to vaccination. So zinc is very important in our immune system. Decreased zinc is found in a whole variety of cancer patients, and decreased zinc is associated with loss of smell and taste changes. So it remains to be seen. I'm sure it'll be investigated at some point if serum levels are actually low in coronavirus patients who are losing their sense of smell and taste. But that's always been used as a screening question when we're assessing for nutrients. So keep screening for that. Zinc may prevent coronavirus entry into cells. So early on, and for prevention, we think about zinc having a role, especially in the oral cavity with lozenges. And we do know that zinc is helpful in reducing the risk of pneumonia and common cold and respiratory tract infections, especially in elderly and in children. So it's got a good track record. We want to be cautious with zinc with too high levels because high dose zinc supplementation will inhibit T cell function. It will also impair copper absorption. We know that 80 milligrams of zinc can increase genitourinary complications in the elderly. And we do know that it can impair the absorption of some antibiotics, so things like Cipro and Doxy. Thankfully, it does not interact with Zithromax, so don't have to think about that. Zithromax being the most common antibiotic being used for coronavirus. It should also be separated from iron, and it should definitely be taken with food to avoid nausea. Yes, hopefully you don't make your children puke by giving them zinc on an empty stomach. That's called learning the hard way. So zinc is wonderful, but it needs to be dosed with food. And zinc 15 milligrams to 30 milligrams is safe for long-term use in adults. But please do watch out for cumulative doses of zinc because it's in a lot of different things. So for instance, I clocked a patient at 110 milligrams of zinc daily. Too much because it was in the multivitamin and it was in their combination immune product number 1 and it was in their combination immune product number 2, and then they were taking it separately and they were taking lozenges. So please make sure to do an inventory of total zinc level because some of our patients will be getting it from a great many different places. And higher doses may be required in a severe infection, but especially for long-term prevention, please just be sensible about dosing because some of the doses I've seen recommended online, like 90 milligrams a day or 100 milligrams a day, is not good for us. So that can be too much of a good thing. Vitamin D considerations for COVID include screening for vitamin D deficiency, which is quite common and rampant in our population. Vitamin D balances inflammation and immunity. It makes sense from every angle as a supportive immune nutrient. The vitamin D signaling enhances immunity while preventing prolonged inflammatory responses. In observational studies, both in Britain and the US, adult vitamin D status had a linear relationship with respiratory tract infections, and in clinical trials, maintaining a serum level of at least 30 or 75 in Canadian units is associated with better respiratory outcomes. In mouse models, vitamin D deficiencies contributes greatly to acute respiratory distress syndrome. So again, vitamin D is very involved in modulating an overzealous inflammatory response. So I think it has a role to play in trying to prevent cytokine storms. And generally, the adult doses are between 1,000 and 5,000 IU daily in winter, but serum levels should be checked because there's quite a huge variation in people's levels and how they respond to supplements. Some people need a lot more and some people don't. And too much vitamin D, because it's fat soluble, can be damaging. It can also cause hypercalcemia. So again, we want to do due diligence and not do crazy high doses for long periods of time because that can end up doing more harm than good. So be moderate. And vitamin A is the same. Although there's more controversy with vitamin A, it has a lot more cautions in my mind, certainly, than vitamin D or zinc or vitamin C. Vitamin A maintains homeostasis in the immune system, very involved in autoimmune conditions, but it has both a stimulating and suppressing action on the immune system, and dose really matters with vitamin A. So, and so does gender. So in boys versus girls, vitamin A will help stimulate immunity in girls, but it'll actually suppress immunity in boys, which is strange, but there you have it. And while it has a role in measles pneumonia, in a randomized control trial of non-measles pneumonia, giving 2,000 IU of vitamin A once and then giving 100,000 the next day worsened the pneumonia, increased the need for oxygen and lung consolidation. And there is a Cochrane systematic review looking at the role of vitamin A in lower respiratory tract infections in children. And their conclusions were that it caused an increase in the incidence of lower respiratory tract infections in one study. It caused an increase in incidence of acute no significant effect on the incidence, although it caused harm in one of the studies. In one study, it increased cough and fever. It increased symptoms of cough and rapid breathing in 2 others. 3 reported no differences and no protective effect of vitamin A. And 2 studies reported that vitamin A significantly reduced the incidence of acute lower respiratory tract infections in children with poor nutritional status, but increased it in normal children. So again, if you're deficient, we should replete that deficiency and that'll make a difference. But if you have good nutritional status, it may not be a good thing to supplement with vitamin A. We just don't know. It's not clear like with the other nutrients. In a randomized controlled trial of obese women, 25,000 units, which is not a super high dose, but for 4 months, which is a very long time, steered the immunity from Th2 to Th1, which is good. But then in almost an identical trial, it also at the same time raised CRP and liver enzymes and serum lipids. Keeping in mind, obese women are more likely to have fatty liver disease, and vitamin A is a fat-soluble vitamin that accumulates in the liver. It's apparently really causing some liver inflammation, and it's extremely rare. I think this is the only case I can find of a natural agent actually raising CRP levels. So that doesn't make me feel particularly good to see that. And on the other hand, in a retrospective study of Ebola patients given vitamin A 200,000 for 2 days, they had lower mortality lower overall mortality. But in a subgroup analysis, if people had been taking vitamin A in a multivitamin before that, they had no benefit to their mortality. So again, I think it's just when you're, like Ebola happened in Africa where vitamin A deficiency is endemic, when you're dealing with a very vitamin A deficient population, it will be really helpful, but not necessarily so in the general population. Serum retinol is a fasting blood test that is not particularly expensive. Insurance tends to cover it. I do encourage practitioners to think about running serum retinol for their cancer patients, for malnourished patients, especially for patients with autoimmune conditions, MS, lupus. You will find low serum retinol in that population in a pretty high degree. If people have chronic diarrhea or fat malabsorption, you want to think about testing them, inflammatory bowel disease. And there is a possibility that statins will increase the risk of vitamin A deficiency because they inhibit absorption of all the fat soluble vitamins. So treat your patients, test whenever you can, especially if they can actually get to a blood draw site these days. If they're going anyways, tack on a serum retinol and see where people are at. This slide is dedicated to supporting natural killer cells because they are such an important part of the immune system in managing coronavirus. We know that NK cells were significantly lower in patients with SARS, that's the first infection, and that correlated with disease severity. And then we have this slide, which I think this slide was started, maybe I started this 15 years ago. We have lots of tools in the toolkit of different herbs and nutrients that support natural killer cell activity or levels in humans. So this is by no means every treatment, but these are all human studies, and some of them are easy to recommend, like blueberries and forest bathing and fish oil, or they're things we're recommending anyways, like vitamin C and melatonin and that sort of thing. So lots of options here. This next part is my best guess. And I felt obligated to at least try and make an attempt to decrease the risk of cytokine storm. I don't know if it will work, but I think it behooves us to try just because cytokine storm is so devastating. In the few articles I could find addressing cytokine storm directly, the researchers talked about things like IL-6 inhibitors, which we're going to get to in a minute, which are drugs being used to address COVID-19 currently. But they also talked about how the limitations of a lot of the pharmaceutical approaches is that they're very narrow in what they target. And the advantage of natural anti-inflammatories is that they're broad anti-inflammatories. They affect COX and LOX. They affect multiple cytokines. And although they're gentler, they're not as strong as pharmaceuticals in general, they are still broad enough in action that I think they can be impactful. So the things that I guess and think might be worth considering to decrease the risk of cytokine storm are vitamin C, IV and oral. The research on that comes from inpatient units with various types of mechanical ventilation. So these are ICU settings, two different meta-analyses, one a little bit more narrow in criteria, but both showing that patients given either oral or IV vitamin C required less time on ventilation. That would potentially free up a lot of ventilation time for other patients who are in need. And we are hitting crunches across the country right now as I'm doing this webinar in not in our ICUs, just not having enough ventilators in some places. The other thing that is proposed by two different papers, and I share the opinion, is that melatonin may have a very positive role to play as an adjunct in COVID-19. At minimum, we know that melatonin for ICU patients improves sleep quality. In mouse models, it decreases pulmonary fibrosis. It's antiviral in multiple strains in mice, and it reduces specifically oxidative lung injury and inflammation during viral infection. So on every level, it makes sense as a potential agent. There is a trial happening right now on melatonin being combined with an antiviral drug for COVID-19. So I'm curious to see about that. But melatonin is something that most of us working in integrative cancer care are very comfortable with. We know that at 3 to 5 milligrams, long-term melatonin improves bone density in women. So there are some nice fringe side effects aside from just it often helps people get a deeper quality sleep. It's not appropriate for everyone. You know your patients, questions in hematology, oncology about whether it should be used or not. But certainly in our solid tumor population and osteopenic women, it is a safe adjunct and might be beneficial in the current pandemic. Licorice root in multiple mouse studies also helps to treat pulmonary fibrosis. and it's very active in vitro studies against SARS. So after SARS happened the first time round, China did a bunch of investigations into which herbs might be the most antiviral, and licorice root came up high on the list, and we've already talked about that. The other thing to consider about decreasing cytokine storm, and this isn't so much mechanistic but just practical with COVID, is that in the ACE2 receptor that COVID is working in, that tends to pump out or lead to the excretion of potassium. So in the critical care units, you can see really hypokalemic patients who need IV potassium. But I think I've already seen in the outpatient setting with more severe muscle spasms what could have been potassium depletion, rapid potassium depletion just from the infection being a little bit higher in the system. So it cannot hurt to take electrolytes and to consider potassium-rich foods like bananas and sweet potatoes and mushrooms if people are in these earlier phases. We have some specific combination of herbs that a Cochrane systematic review showed to be useful from SARS, so we could think about those as well. And then with slightly lower level of evidence based on mouse models of pulmonary fibrosis, we would consider things like quercetin, curcumin, turmeric, soy isoflavones, flax seeds, vitamin E, CoQ10. So that gets more stretchy into the theoretical realm, but they're good natural anti-inflammatories. Many of them are good during allergy season. Both curcumin and quercetin have research on allergies, and the high pollen allergies are not helping the cause with potentially with coronavirus spread because of the topical inflammation that causes. And there's a lovely Jacob Shore little short on that in Natural Medicine Journal. And the last thing I wanted to talk about alongside this idea of trying anything to decrease the risk of cytokine storm, as long as it's safe to do, or people are doing it anyways, is to decrease or to target interleukin-6. So in SARS-CoV-2 patients, so COVID-19, interleukin-6 is universally, and tumor necrosis factor alpha are universally high and associated, lower levels with mild cases and higher levels in more severe cases. What else to say about it? Interleukin-6 impairs our immune system. It's not even though initially it might upregulate immunity, long term it's very bad because it inhibits T cell responses. And there is a drug called tocilizumab, TCZ for short, which is a monoclonal antibody. We should be familiar with the monoclonal antibodies from cancer care that blocks interleukin-6. And there is a retrospective study that was just published of this IV IL-6 inhibitor really having pretty dramatic responses in COVID-19 patients, improved oxygenation, improved CT scans, improved immunity generally. So again, that connection between too much inflammation suppressing the immune system, the lymphocytes being affected. So that is a potential treatment that we're going to see more of, I think, those IL-6 inhibitors. We also have a case report of a renal cell carcinoma patient who was treated with that monoclonal antibody anyways, who had happened to have COVID and had rapid control of their pulmonary hyperinflammation after taking that IV. So things to think about that are natural IL-6 inhibitors that we know about, that we have human studies on. I think they sound familiar by now. Vitamin C, vitamin D, fish oil, CoQ10, turmeric, melatonin. Interesting one on Agaricus blazei mushroom, yoga, and then there was a homeopathic combination that also inhibited IL-6. So last slide is just a little side note on potassium in severe COVID patients. Again, it's not in our wheelhouse because this is happening in the ICU, but I think it's good to keep it on our radar because we might possibly see lower levels of potassium in the outpatient setting. And the last two things I wanted to quickly cover were considerations for nebulizing, because there are a lot of patients buying nebulizers and using nebulizers regularly as a prevention, because that's the advice that's going around on the internet. Just safety considerations are that nebulizers do aerosolize the virus, and so they can really infect people around them. In clinic and hospital settings, they're really discouraged or only used in a negative pressure room because of this aerosolizing of the virus. So please be mindful of that and take care of your families or people living in the home with you if you're nebulizing. And there is a previous case report of hydrogen peroxide nebulized causing interstitial lung disease. It's one case report, but it does give me pause. Dose would certainly matter, and frequency would also matter. But I just want people to be aware that this is not one of our really well-established cold and flu remedies with a long history of safe use, because it just doesn't have that there yet. And it may not. It could go either way. We just don't know. And on the other hand, with essential oils and steam inhalations, we do have a high safety profile there, precedence in asthma in people using those. So I'm not advocating any nebulizing at this point with any of my patients, just because I don't feel that there is quite enough research to support advocating for that. And I do think people should be advised about potential risks as well. And then post-infectious considerations, just reminding everyone that people will shed the virus for a long time. I know we talk about these 2-week isolations, but in China with COVID-19, the average is 20 days, which is more like 3 weeks of shedding. Again, the shedding will lower with time, but just to be mindful about that. Cancer patients recovering from COVID-19 might benefit from extra supportive care with herbs. So consider some nourishing lung yin formulas. There's some suggestions from Dr. Winston Cardwell. And also it's a different context, but we have from radiation fibrosis studies an idea of some herbs that can help with pulmonary fibrosis. So if we've had a pretty severely ill cancer patient who's recovering from coronavirus, we can at least have a model of an idea from Chinese medicine about what herbs might be useful. And I'd like to conclude this part of the lecture with an awareness that there is a study going on to track integrative management of outpatient COVID patients. You can click on there and describe how the case was managed, what kind of integrative therapies were used. So please do enter in some data when you think you've got a good case report where you've seen something interesting or a good response to a therapy.